Hi, Miss Rose. I'm Persia, the physician assistant taking care of you today. Can you tell me what's going on?
My stomach pain is so much worse, and I'm bloated, and I've thrown up twice, and I haven't had a bowel movement in 3 days or past gas.
I'm sorry to hear that. So, given your history of colon cancer with liver involvement, I'm concerned about your bowel. Mercedes, do you mind getting me a full set of vitals, please?
Yeah, no problem. All right, so I'm going to take the vitals of Miss Rose. After taking her blood pressure and her vitals, it says that her blood pressure is 108/68. Her heart rate is 108. Her respiratory rate is 20. Her SpO2 on room air is 96%. Her temperature is 37.9 degrees Celsius taken by mouth, and her pain is at an 8 out of 10.
Copy. She's tachycardic but protecting her airway and breathing well on her own. Distended tympanic, hypoactive bowel sounds, diffusely tender, no rebound or guarding. Given her history, this looks like a malignant large bowel obstruction until proven otherwise. Mercedes, 18 gauge IV, 1 liter normal saline bolus, CBC, CMP, lactate and type and screen. She's NPO starting now, and I'm paging general surgery and requesting a stat CT.
All right, so I'm just confirming IV access, 1 liter bolus, CBC, CMP, lactate, type and screen, and an NPO status, and we're going to start that right now.
Thank you. Shauna, likely large bowel obstruction with liver mets. What do you recommend for pain and nausea?
Let's see. Hydromorphone 0.5 milligrams IV for pain, and that's safer than morphine given her liver involvement. And then let's do ondansetron 4 milligrams IV for her nausea. An important flag here is let's not give metoclopramide. It's a prokinetic and a mechanical obstruction. It can worsen things or raise perforation risk.
Copy. Great catch. Hydromorphone 0.5 milligrams and ondansetron 4 milligrams IV, holding metoclopramide.
All right, confirm. I will go administer that now.
Thank you.
Radiology, this is Alex.
I need a stat CT abdomen and pelvis with IV contrast. Concern for large bowel obstruction.
Copy. Verifying renal function and IV access before transport. All right, let me confirm the patient ID, checks IV, transport to CT, and then positions the patients. Miss Rose, you'll feel warm or notice metallic taste when the contrast goes in. That's normal. I need you to hold still and briefly hold your breath.
You can breathe. Okay, here comes that contract.
Wait.
Hey doctor, so CT shows a partially obstructing descending colon mass with proximal colonic dilation, cecum about 8 centimeters, consistent with malignant large bowel obstruction. Multiple liver mets, unchanged, no free air. Surgeon Jordan and oncologist Shayna, can you both please take a look?
Okay, I will pull up the patient's chart. Okay, thank you. So I'm looking at it, and given that there's no rebound, no guarding, no peritoneal signs, and no free air on the CT, this is not an emergent surgical abdomen tonight. So I'm going to recommend an NG tube for decompression and continued NPO and IV fluids and serial abdominal exams. We can check back in the morning, but let's also loop in the oncologist. Okay, thanks.
Agreed. Priority right now is relieving the obstruction, not chemo. She can't tolerate systematic treatment while acutely obstructed. Once she's stable, we'll reassess whether a colonic stent or diverting colostomy fits better and coordinate with Jordan.
Copy. NG tube, continued NPO and fluids, serial exams, no OR tonight, and surgery and oncology will coordinate on definitive management. Mercedes, can you set up for NG placement?
No problem. I'll confirm that NG tube for compression, and I'll set that up now.
Thank you.
I'm Gabrielle. I'm going to be your dietitian. Given your recent weight loss and this obstruction, I'm recommending we keep you strictly NPO for now, and I'll reassess your and advance your diet once you're cleared.
Okay, I understand.
So that's our initial stabilization. Fluids, pain, and nausea control, NPO, NG tube for decompression, imaging complete, and surgery and oncology on board. Let's regroup once pharmacy, nursing, and social work have more information. Okay team, let's huddle. I understand we've got new information that may change our plan. Shauna, what do you have from pharmacy?
So I did a more thorough med rec with Mrs. Rose's daughter and found out that she actually took an extra dose of her home oxycodone about an hour before she arrived. She was in so much pain, she didn't think to mention it, and it wasn't captured at triage. So that means the hydromorphone we already gave her is stacked on top of an unaccounted opioid dose. Real risk for oversedation and respiratory depression here.
Yeah, that's a significant catch. What do you recommend?
Let's hold any further opioid doses for now. We'll move to continuous pulse oximetry with frequent respiratory checks and keep naloxone at bedside. Once we're confident the home dose has cleared, we can resume scheduled dosing at a much lower starting point.
Copy. Holding further opioids, continuous pulse ox, naloxone at bedside, reassessing before resuming pain medication. That changes our medication plan significantly, so good catch.
All right, confirming that I'm holding opioids, continuous pulse ox on, and Naxalone at bedside.
Mercedes, anything else from your bedside assessment?
Yes, so her daughter arrived and is telling us that her mom never wants an NG tube placed, that she's suffered through enough. But Miss Rose seems torn. She hasn't said no herself, but she's not pushing back on her daughter either.
Okay, that's important. We need to hear directly from Miss Rose, not just go through her daughter.
Sure.
Miss Rose, I want to check in with you directly. How do you feel about the NG tube we discussed for your comfort?
Honestly, I don't feel great about it, but I trust you guys, and if it'll make me feel better and help my daughter not worry.
Okay, well, thank you for telling me that honestly. We'll go ahead with the NG tube. I'm going to loop in palliative care to help support you in your daughter through this, okay?
Hi, I'm Sarah. I'm the palliative care specialist. Ms. Rose, I've heard that there's some tension about the plan. I'd like to sit down with you and your daughter together, make sure everyone understands your wishes, and support you both through these decisions.
Palliative care will help mediate and confirm goals of care with the patient and family together. Selena, what did you find on your assessment?
A significant barrier. Miss Rose's electricity at home was shut off last week for unpaid bills. That means no working refrigerator, which matters because some of her medications going forward may require refrigeration, and it's also a basic safety issue for her at home.
That absolutely changes our discharge planning. What do you recommend?
I'm connecting her with our hospital's financial assistance program and a local utility assistance fund to get her power restored before discharge. In the meantime, I'll coordinate with pharmacy on any medications when she leaves.
I can help with that. I'll double check that her discharge medication list for anything that needs refrigeration and suggest alternatives, or arrange a safe cold storage plan if there isn't one.
Copy. Social work is addressing the power and financial barrier, and pharmacy will adjust her discharge medications accordingly. Exactly why we loop everyone in before sending someone home. Our working diagnosis is malignant large bowel obstruction secondary to metastatic sigmoid colon cancer. Regan is currently responding to stabilization, so let's confirm each part of our unified care plan.
So from a general surgery standpoint, we're going to keep her NPO with the nasogastric tube decompression going. We will keep with these serial abdominal examinations while we evaluate whether colonic stenting is feasible at this time. If there's any indication of perforation, ischemia, peritonitis, or deterioration, we will reassess and for possible surgical intervention.
From oncology, systematic treatment will remain temporarily held during the obstruction. After stabilization, we will reassess her cancer status and determine the next treatment strategy for her.
Alright, so from pharmacy, we discovered an unreported extra home dose of oxycodone before arrival, and because she also received the IV hydromorphone here, we are holding any additional opioids for now, using continuous pulse oximetry and frequent respiratory assessments, and keeping naloxone available at bedside.
From palliative care, we will continue symptom control and ensure that any procedural or cancer-related decision reflects Reagan's preference for continued treatment while avoiding unnecessary treatment burden.
From nutrition, she will remain NPO during her active obstruction. Once it is safe to resume intake, we will gradually advance her nutrition and address her recent weight loss.
From social work, transportation, medication, affordability, home support, and possible autonomy needs will be addressed before discharge, and essential follow-up appointments will be arranged.
From radiology, the current imaging confirms the obstruction without evidence of perforation. Additional urgent imaging can be coordinated immediately if her status changes.
All right, from nursing, Miss Rose confirmed that she personally wants the NG tube despite her daughter's concerns. I'll continue NG decompression, IV fluids monitoring, and frequent reassessment while closely watching for respiratory depression or clinical deterioration.
I understand the plan. I want to continue treatment, and I do want to be involved in deciding what procedure is best for me.
Plan confirmed. We will continue stabilization and reassessment as an interprofessional team.